Hello and welcome everyone. This is Praveen. I'm a postdoctoral research fellow in radiology at the National Institutes of Health, and I am excited to be a part of the ACORE blog series. And today I'll be talking about an important question, which is, can photon counting CT match MRI PDFF, that is proton density fat fraction, in quantifying liver fat? So we will be reviewing a recent study that was published in the Journal of Radiology looking at whether PCCT can serve as a practical non-invasive alternative to MRI PDFF. And I would like to thank Dr. Sharif Ghosi for his help and guidance with this work. And for more details or to view the sources used in this presentation, please check out the full blog post and the references linked below. So let's start with a little bit of background. Liver steatosis or fatty liver disease affects nearly 40% of the world's population, and it increases the risk for fibrosis and cirrhosis. The gold standard for diagnosis has traditionally been liver biopsy, but it's invasive and it only samples a small part of the liver, which means it can miss the disease in other areas. And the MRI PDFF is the non-invasive reference standard, but the downside is it's costly and it's not always easily accessible. So photon counting CT is the new CT technology that uses advanced detectors to capture X-ray photons individually, and it provides better imaging detail compared to the conventional CTs. So the key question is, can PCCT match MRI PDFF in accurately measuring liver fat? And if so, could it offer a practical alternative to MRI for routine clinical use? So the goal of this study was to see if photon counting CT can measure liver fat as accurately as the trusted standards like the MRI, the biopsy, and the transient elastography, which is an ultrasound based technique. This was a prospective study of adults greater than 18 years of age with known or suspected liver disease, and they were included if they had a contrast enhanced photon counting CT done between Feb 2022 and Jan 2024, and also a reference test done within 120 days, just to make sure the liver fat measurements were still comparable. And patients were excluded if their scans had major artifacts, or if they had any liver tumors, or cholestatic or vascular liver disease, or if there were any major treatment changes between the PCCT and the reference tests. So in total, 178 patients were included. All had PCCT and one of the three reference standards, which is 125 patients had MRI, 26 patients had ultrasound, and 27 patients had liver biopsy in addition to the PCCT. Now let's talk about how the liver fat was measured. So on PCCT, the regions of interest were placed in liver segments 3, 4A, 5 and 7. They used the three material decomposition, which is a technique that separates iodine, the liver tissue and the fat based on their attenuation profiles. This is how the virtual non-contrast images were created, that is by mathematically removing the iodine signal from the contrast enhanced scans. This was compared against MRI, where they placed the similar regions of interest on the PDFF maps uh, and measured the relative amounts of fat and water in the liver to give the precise fat percentage. And this was graded from grades 0 to 3. And for biopsy, a pathologist graded the percentage of hepatocytes containing the fat using the NASH Clinical Research Network System criteria, and this was also graded from grades 0 to 3. And for transient elastography, they calculated the CAP, which is the controlled attenuation parameter, uh, which is a measure of how much the ultrasound signal weakens or attenuates as it passes through the liver. So higher fat content leads to greater signal loss, which is reflected in higher CAP values, and it is measured in decibels per meter, and this is also graded from grades 0 to 3. Let's take a quick look at the main findings. The photon counting CT showed excellent agreement with MRI PDFF with an ICC of 0.91, that is the intra-class correlation coefficient, and it showed a moderate correlation with biopsy and ultrasound. A 4.8% fat cutoff on PCCT could reliably identify steatosis with good sensitivity and specificity, and we will break this down further in the next slides. The intraclass correlation coefficient is a metric that tells us how closely two methods agree. An ICC of over 0.9 is considered excellent, and here it was 0.91 overall. And when stratified for patients with and without fibrosis, it again showed excellent agreement. The ICC was 0.84 in patients with fibrosis, and it was 0.92 in patients without fibrosis. And a bland Altman analysis was also done to check for systemic bias. It shows whether one method consistently over or underestimates compared to the other. So the mean bias was 0.81 with narrow confidence intervals. That means these two methods were well aligned, and so in short, the PCCT closely aligns with MRI for liver fat quantification, even across different clinical profiles. So let's talk about the Uden index. This is a cutoff point on the ROC curve that maximizes the combined sensitivity and specificity. This was 4.8%. So at this point, the PCCT achieved a sensitivity of 81%. That means it correctly identified most patients with steatosis, and a specificity of 71%. That means it correctly excluded most patients without steatosis. And to confirm reliability, cross validation was performed, and it also showed consistent results with sensitivity at 75% and specificity at 70%. So overall, these findings demonstrate that PCCT offers solid diagnostic accuracy for detecting hepatic steatosis. So in summary, photon counting CT can correctly measure liver fat with results similar to MRI PDFF, and a 4.8% liver fat threshold correctly detects steatosis with good sensitivity and specificity. But before this can be used in routine clinical practice, broader multi-center validation is needed. But it has a lot of advantages, like it is fast, it has fewer artifacts, and it can have broader patient eligibility. So the key take home message is the photon counting CT has the potential to change how we assess liver fat in daily practice, moving us one step closer towards faster, non-invasive, and more accessible liver imaging. So this concludes my presentation for this blog. For any additional details on this article, please see my blog below. Thank you so much for watching.